So please give us a little bit about ourselves and then we can jump straight into some juicy questions. Welcome. She froze. There you are. Are you there, Kiri? Maybe our internet is giving a bit of trouble. Hi.
Oh boy.
Technology today.
Thank you so much for having. I'm here. Can you hear me?
Yes, go ahead.
Can you hear me? Good, thank you. Okay, guys. So hi, I'm Dr. Kiri-an Bridgewater-Lyon. I am an obstetrician and gynecologist who is an avid supporter of all things women's health. I'm a girl's girl. I have a baby girl that I just had recently. And this particular area is one of my potential pet peeves when it comes to healthcare and women's healthcare, because I do feel that it is an area that is very widely misunderstood and not explained, not advocated enough, and not explained enough to our women. And so that's why I'm really happy that Nikki asked me here. I know both Nikki and Natalie, and I'm glad that they've asked me here to spread some correct information about menopause and about the options for menopause, because I think the narrative has been skewed for far too long. Nikki, I think you're muted. I can't hear you.
Okay, I'm here. Okay, so menopause, let's just jump straight into it. What is menopause? Just give us that definition. What is menopause?
Okay, so menopause itself is actually not the big problem. So menopause is defined as when a woman has stopped seeing her period for 1 year. So 12 months consecutively of no period, then you're in menopause. But of course, that requires you to have no missed your period for 12 months. And if you're someone who is in the perimenopause or who went through menopause, you'll understand that very rarely is it as linear as that. It's not a light switch that, 1 minute you're menstruating and 1 minute you're not. And so it's what we call a retrospective diagnosis. So it's not until you've already gone into menopause that you can then look back and be like, oh, that was menopause. I am officially in menopause. And that's the textbook definition of menopause. However, what is more important, I think, is the perimenopause, which is that flux of period leading up to menopause. When persons might notice that their period goes for 2 months and then it comes back. Or, their period, they might go for 4 months and then it comes back, or 6 months, and they're like, yes, I'm halfway there. And then you get your period and it lasts for 2-3 weeks. And you're like, what is this? That's typically the time when a lot of the other symptoms start to show up as well, right? Which are menopausal symptoms, but they can be present in the perimenopause. So the things that we talk about a lot, like the hot flashes, the night sweats, the difficulty sleeping, the things that we don't talk about as much, like the brain fog, the abdominal fat deposit, the depression, the mood swings, the heart disease, the elevated blood pressure, the elevated cholesterol, all of these things can start happening from in the perimenopause. And so to me, the perimenopause is even more important than menopause. Menopause is like a medal that you get for achieving the full 12 months, right? But perimenopause is more important because that's when it really starts to affect your life. And perimenopause, unlike menopause, is a lot harder to define because it varies from person to person. So perimenopause can last for a few months up to several years. Somebody can be in the perimenopause for almost close to a decade before they actually going to establish menopause. And so it's really important, I think, to educate persons about the perimenopause and about these symptoms and about what they can do during this time as they wait to fully transition into menopause. Additionally, I think it's also important to note that, as I mentioned, it's not a light switch. So even after you've attained the 12 months of not seeing your period, and you think to yourself, oh, thank goodness, it's over. It may not be, right? The symptoms of the menopausal symptoms can start before menopause, and they can continue even after establishing menopause, aka no period for 12 months.
I did not know that. So you really can have all of the same symptoms after you have not had a period for a year. You can still have all of
Yep. And it can ebb and it can flow. It can ebb and flow. You can actually be okay, and then you suddenly get a resurgence. Like, I'll be honest, I hope she doesn't kill me, but she's pretty open like myself. My mom came to me the other day and she's like, Kiri-an, what is this? I went through menopause, Donkey Kong, not Donkey Kong, but I went through menopause already. I was fine. I'm almost convinced I'm getting hot flashes again. Can that happen? And I'm like, yes, it can. It can ebb and flow. Just like Natalie looks distraught.
Let me go get the tissues.
No, it can. It will ebb and flow because it is a transition period. It is a transition period. And I think that's one of the important things to consider when you're thinking about menopause. Just like how puberty doesn't just happen just so for the vast majority of persons. You know, you get your period today, and in most adolescents, the period goes away. They don't get it again for several months. You know, and even when it does come back, it's all kind of blotchy, helter-skelter, all over the place. You know, the acne gets worse and it gets better. It's all over the place. Just like how your body transitions in a very haphazard way at the beginning, it transitions in a very haphazard way very often again at the end. Now, some women are blessed and they don't have these problems, but I would say they're the unicorns out there based on what I see in my practice.
Oh yes, I've been hearing some people say, "Oh, I don't get any hot flashes." I'm like, really? You're sure? Okay,
They may not have hot flashes, but they may have other symptoms. Everybody gets different pieces.
yeah.
What are all of those symptoms? Because you hear some strange things and you wonder, are people just attributing this to this transition phase, or are these really some of the symptoms?
Yeah, so there are tons of symptoms. And I think, honestly, as we are learning more about it and we are investing more of our time, our effort, and our finances into finding out more about it, I think more is being revealed to us. And we're having more aha moments when it comes to symptoms, because things that were not typically labeled as menopausal are becoming labeled as menopausal. And I know when you're in that kind of space, there is going to be a space for wondering, hey, are we overdoing it now? You know, and I think, you know, even with like endometriosis, I think there was a point where people kind of went, everything's being called endometriosis. Are we overdoing it now? I think also it's another thing that's non-gynecological is like people on the spectrum, you know, a lot of persons are getting diagnosed and people are like, are we overdoing it now? But I don't think we are, to be honest with you. I think in each one of those cases, I think we are just becoming more informed. And so when it comes to menopause, the stereotypical ones are the hot flashes, right? So those are the sudden wave of heat that takes over your body. You will be chilling. I mean, according to the reports, it's going to be super hot for the next couple of days. I'm not talking about that heat, right? But yeah, so you'll be in the room chilling, you know, you're in the AC at work, and you just feel this wave of heat come over you. You just start to feel yourself. If you're of that ethnicity, you may actually become flush, you may become red. Otherwise, you may actually feel yourself start to perspire, and it's like, oh, what's going on here? That's the typical history that I get from most of my patients when it comes to a hot flash. And hot flashes can be very problematic for persons because, one, nobody really likes heat like that, especially unless you're at the beach and appropriately attired for it. But also, it can be a social embarrassment for women as well, because you will be in these, most of our women nowadays, especially in their 40s and in their 50s and their 60s, these are high functioning women, you know, these are women still in the work office, they're still in the boardroom, they're still, you know, commandeering the big ships, whether it be their personal family ship, whether it be their business ship. So you will have people in a boardroom meeting and you suddenly start to perspire, your clothes are wet, and you have to now explain to people around you, why are you suddenly in this state, you know? And that can be very, very, very off-putting and, you know, very, very sensitive of a situation to find yourself in, right? So hot flashes are one symptom, what that we talk about a lot. The other ones I think we talk about a lot are the difficulty sleeping. So the same hot flashes can happen in the night. They're called night sweats. So it can happen while you're sleeping, and it can actually wake you up out of your sleep. That can cause difficulty sleeping, but also insomnia can happen from menopause as well. So with or without a hot flash, you can just find yourself having a difficult time getting to sleep, all right? Another symptom that is common is, well, that is, I think, becoming more common is forgetfulness. So there is a higher risk of low cognitive function. So you might find that you're forgetting things more often, etc. And what we're finding out is it's not just limited to forgetting things, but you can actually just have brain fog in general. You know, I think everybody has become more or less accepting of mommy brain, right? But there's menopause brain as well. right? People can have a certain, like, just this sense of confusion, like sense of, and it's very vague. It's very hard to put your finger on, but you're just like, I'm just not functioning the way I used to function. I'm just not able to do the things I used to do the way I used to do it. And I'm not sure what it is. And that can sometimes be menopause, right? You can also have, of course, now we're talking about people not being able to function properly. Oh, no, one of the top ones, vaginal dryness. That's another one that we talk about a lot. So persons can get vaginal dryness and also a combination of the two. So you could feel for sex, but just not be getting lubricated, or you could also just not have the desire at all and not be getting lubricated. Both of which are problematic, especially if you have a partner. So those are some of the ones that we talk about a lot. I think those are the ones that get a lot of airplay. But there are other ones. So there's dementia, right? There is a higher risk of dementia or long-term memory loss for persons who go through menopause. There is, the increased abdominal fat. So a lot of people are just like, listen, doc, I can't lose the weight. I don't know what's going on. I haven't changed my diet. I'm still exercising. I can't lose the weight. What's going on? So you get what we call truncal obesity. So it's harder for them to manage their weight. And especially the midsection, you might notice that that's getting thicker and thicker, and you can't explain why. That can be a symptom of menopause. It can also affect, it can increase risk of depression, actually, right? So women who are going through the perimenopause and are in the postmenopausal state are at a higher risk of depression. And these are a lot of the outward ones. Oh, fatigue. It can cause fatigue as well. Just low energy output, that kind of a state of bah humbug, kind of just all the time. It can cause that kind of a sensation, which again is a big one that people might be like, oh, you just need to drink a little this or this and that. And no, it's something physically going wrong with your body because of your hormones. Also, there are things that are going on inside of your body. So it puts you at a higher risk of high blood pressure, puts you at a higher risk of high cholesterol levels. When those two come together, there's also a higher risk of heart attack. There's a higher risk of stroke as well. And so menopause affects, yes, it affects a lot of areas. And this is just how it's affecting the woman. Remember, we as the women, we are pretty much the cornerstone of a lot of the family, you know? And so when women are going through all of this, it affects their relationships with their partners, relationships with their children. I mean, the effects are very far reaching for the woman, for her family, and for the society at large.
So what do we do?
That's what he's like, okay, so you have me depressed. What do we do?
I know. Before we jump into that. So basically when we start to, there's a question that we have, and the question is, so how do I know that I'm in perimenopause? So do we get diagnosed? Does it matter?
Right. So do you have the symptoms? It's really a symptom-based thing, okay? If you are having the symptoms and you are between the ages of 45 and 50-something, odds are that's perimenopause, okay? If you're under 45 and definitely under 40, then certainly we need to look at other things that can be causing it. But generally speaking, if you're within that age bracket and you're having these kind of symptoms, consider yourself in perimenopause. You're probably wondering then how long is it going to last? As I mentioned before, it varies from person to person. Nobody, but God, not even you, but God, or whatever deity you believe in, knows when you're going to come out of it. And it's really about speaking to your practitioner, letting them know that you're going through this thing, letting them know how it's affecting you, and coming up with a plan to help you to transition better, to help you not to suffer, because unfortunately that is the narrative we've been given for a very long time, and it is absolutely not necessary.
Yeah. Can your period be regular, but you be getting these symptoms and it be because of perimenopause? Or does the period have to start changing?
No, you can be having a regular period as well. Because the irregularity of your period is just one of the many symptoms, right? It's not like the defining one.
Okay.
Now, when you do, I want to make a note though, if you do go to your doctor and have the symptoms, you should do blood work to rule out other things, all right? Because there are other things that can cause it. So thyroid issues can cause some very similar symptoms. Thyroid issue can make you very moody. Thyroid issues can make you have irregular periods. Thyroid issues can affect your weight. Thyroid issues can affect how you tolerate the heat. So there are other conditions that can present very similar, and therefore you should have those things ruled out before, because we don't want you to be having thyroid issues and you're taking hormone replacement, or you're doing exercise and thinking, okay, this is a menopause, right? So you do want to get blood work and get checked out to make sure it's nothing else. But provided those things are not present, then yes, that is the perimenopause.
Okay, so we've gone to our doctor, we've gotten all these tests, we've found out that we're in perimenopause. What's the next step that we do?
Well, the next step is really getting your life back as best as possible, getting you to function as best as possible. And what that looks like will vary from person to person. So Natalie is going to love it. Everybody else may hate it, but the real best thing you can do for yourself at baseline, exercise and eat right. All right. No, I know it's always like this. When somebody says that, especially when you're having these so severe manifestations. But the truth of the matter is that's one of the best ways that you can combat a lot of these things. Exercise will help with mood. Exercise can help with some of the hot flashes. Exercise can help with the depression. Exercise can help with the weight. Exercise can help with the blood pressure, the cholesterol, eating healthy, all of these things. So exercise and a good, healthy diet is baseline mainstay, right? Anything that you do otherwise, I honestly think it should be done as an additive to that, not as a replacement for that, right? That's the best thing that you can do for your body, hands down, present, tomorrow, and forevermore type of situation. That being said, exercise that won't necessarily fix all your problems. It may not fix vaginal dryness. It may not fix other things. And so there are other treatments that can be done as adjuncts, right? Or additives. Additionally, how we treat each person is going to depend a lot on their symptoms. So I'm going to give a list of options, but for each woman, I would again emphasize that you need to see a doctor and have it tailored to your symptoms, because one treatment may work good for vaginal dryness, like a vaginal cream, an estrogen cream will work really good for vaginal dryness, but it's not going to do anything for your insomnia, right? And if you are not sleeping well, odds are you're going to be cranky, and you're probably going to have a decreased libido anyway, because you don't want this man to touch you because he sleeps and snores beside you all night while you're staring at the ceiling, right? So your vagina will be well lubricated, but you will not want to use it, right? So I say this to say, no, but I'm serious. So each treatment varies and they have different effects. And so you need to have a holistic, an individualized approach and a holistic approach to what's going on with you. All right. So yeah, diet and exercise is the mainstay. Again, Natalie is going to love this. Everybody else may not, but supplements, right? So supplements, using things like your magnesium, glycinate, especially if you're having anxiety. Oh, beyond depression, menopause can also cause anxiety, all sorts of mood swings, right? So the magnesium glycinate can help with mood stability and things of that nature. You can use things like omega-3s to help. Vitamin B, vitamin E, you can use even things like black cohosh can help as well. Some people use ashwagandha, etc., right, to help with balancing some of the highs and lows that are going on with your body. So supplements definitely help as well. Beyond supplements now, you're going to go into a medical grade treatment. And that's where I now come in, or where your gynae now comes in. And that's now with the use of hormone replacement therapy, all right? No, hormone replacement therapy has pretty much become a bad word. It was a bad word for several years. And so a lot of people might be like, oh, she's interesting. She's actually saying we can do that. Yes, hormone replacement therapy is actually usable and is safe. There's been a lot of bad press about it because of an initiative, because of a study that was done several years ago called Women's Health Initiative. I'm not going to go too much into that, but long and short of it is they really chose a bad set of persons to study, and they were very biased about how they published the information about it. And it has caused a lot of persons to be very anxious. Actually, I would even say fearful of hormone replacement therapy, but there need not be. When done in the right timeline and with the right treatment, hormone replacement therapy can help you to regain your life, decrease your symptoms, and have little to no effect on your risk of cancer, because that's a big scare. A lot of people think hormone replacement therapy and they think, oh, but you're going to get cancer, you're going to get breast cancer, you're going to get womb cancer. No. If done and selected properly, you will not be getting that if it's done in a proper way. And hormone replacement therapy can be in the form of estrogen only. It can be in the form of estrogen and progesterone as well.
So if you are experiencing the symptoms, such as even the blood marker symptoms like the cholesterol, the blood pressure, and you go on HRT, those symptoms will improve?
Right. So for most people, well, most people, yes, right? As I said, it will be geared towards what your symptoms are. So if your problem is really just the cholesterol and the high blood pressure, then HRT may not really be the best thing for you. Perhaps you need to focus more on the diet and the exercise, right? If it is that you're having hot flashes, then yes, HRT is probably going to be a better source for you. And even if you're having the hot flashes with the other things, then yes, HRT is more of an option for you at that point in time.
Okay. And how long before you start to see an improvement in the symptoms?
It varies, but most persons within like a month, they're able to feel significant improvement in their symptoms. Sometimes we'll tell people to give it a few more months just to see, but and dose them appropriately. But within a month, you should definitely feel visible improvement in your symptoms, tangible improvement.
I love that. So so you go on HRT. Is there any specific type of method, creams, pellets, all of these things that are beneficial, not beneficial, or is it custom?
Yeah, so again, it will vary on your symptom profile, right? So the type of ways that we can administer hormone replacement therapy are one, transdermally, so those are the patches, right? Orally, so those are pills, and creams that we insert vaginally. Pellets are a form of HRT called bioavailable or bioidentical HRTs as well, all right? And those are the ones that are placed under the skin, okay? What you need will vary depending on your symptoms, and therefore the route will be tailored to such. Ideally, transdermal, the patches are thought to be safer or better than the pill because it's less absorption. And then the vaginals have even less absorption, but again, their benefits are also limited. They're really only for vaginal symptoms. So it will depend on what your problem list looks like, and then it will be tailored to such.
Okay, so you touched on BHRT, bioidentical hormonal therapy. So let's talk a little bit about that because everything that you see in the news, they say it's good, it's not good, it's a marketing technique. Give us a little bit more about what exactly is BHRT.
Okay, so BHRT is called bioidentical. Why do I keep saying bioavailable? But yeah, bioidentical hormone replacement therapy. Ha ha ha. So what it's marketed as is that it's thought to be more natural, more in keeping with your body's natural occurring hormones and tailored to your needs, and therefore to be safer than what we call traditional hormonal replacement therapy. All right. Now, as to whether BHRT is good or bad, I don't believe it's particularly good or bad. The problem that we have with it is it's marketed a little erroneously because BHRT and traditional HRT are actually basically the same compound when you look at it. And therefore, it's no safer than traditional hormone replacement therapy. All right. It's not. And that's where I have a problem with, and a lot of the governing bodies have a problem with BHRT in that how it's being marketed and told to persons. Additionally, the other concern that persons have about BHRT is that it's not regulated. It's not regulated by the Food and Drug Association, which is the governing body that says, that does the regulation. So they make sure that the big pharma makes the compounds in a certain kind of area, a certain kind of lab. They make sure that the dosing is what the dosing is supposed to be. What's on the label is what is inside of it. They do checks on the companies intermittently to make sure that they are adhering to the rules and regulations. BHRT is not governed by that body, and therefore by right, they can put anything on their label and it can be completely different from what's inside of the actual medication, right? And so the lack of monitoring, right, and supervision over this area is what gives people a lot of concerns. Plus, the way that it's marketed makes persons a little bit weary about their use, especially based on the Menopausal Association, the American College of Obstetrician and Gynaecologists, and these are all the big governing bodies that we have, all right? So you're probably wondering, why didn't I just look out against it then, right? Because it seems pretty straightforward, right? My thing is that BHRT may have its place, we just haven't regulated it properly yet. it's no better than traditional, but it does give certain arms that we don't have in traditional. So in traditional, we have estrogen and progestin. We don't have a testosterone option in the traditional hormone replacement therapy. Bioidentical does. And therefore, I think there may be a role for borrowing from them or, interfacing, but we're just not there yet because it would require regulation. It would require testing. It would require more concrete information. And just because something's new and it's not fully tested yet, to me, doesn't mean that it's necessarily bad. We just don't know enough. Similar to when boric acid came out for vaginitis. Everybody went against it. But the truth is, we're not realizing it may have its place, depending, right? And so I think it's more about getting more information about it to know how to utilize it as best to make sure that it's safe and doing what it needs to do for the persons that are receiving it.
I think that's quite interesting. So not to get caught up on the actual BHRT.
No,
I like
they're all bioidentical.
Yeah, I love the fact that you give that clarity because it's been put out there. Oh, BHRT is better than HRT. So now that you've done that clarity, I think that's really good.
Someone said, oh, just go on the pill and that'll sort your hormones out. What do you say to that?
So the pill is, I tell people, the pill is the interesting thing because the pill does by right have estrogen and progesterone. However, the formulations that we use in the pill are slightly different from the formulations that we use in actual hormone replacement therapy. And so, no, I do not advocate for persons to be on just to pick up a pack of pill because, hey, especially in our country, what you might do is pick up a mini-Gynon, a good old trusted mini-Gynon, or a good old trusted Pearl from back in the day. And the formulations in those are actually going to be quite dangerous to women that are over the age of 35 or 45, especially, right? So no, I don't recommend that you just go on any old contraceptive pill, and certainly, most definitely not without discussing anything with your OBGYN.
Okay, well, I think we have a lot of questions that came in. Actually, stop people coming in. So what I want us to do is, Natalie, we have some questions in the chat. Why don't we answer those and then we can go, because we had a lot of people ask a whole bunch of questions. I think we need to have a part 2 with you. We definitely can't do this in an hour as well. So we have a question here. You want to read out that one?
Wow, okay. I'd like to know if I'm perimenopausal, but I don't know if doc can diagnose people just blanketly like this, but I'm 46. I'm going to be 47 in October. I've been seeing my period since I've been 9. I've never missed a period except when I turned 40 and use birth control to stop it. I have very heavy cycles. I have a fibroid, one on the outside of the uterus. My reason for thinking I'm in perimenopause is heat, sweating, which starts on my forehead, then takes over my entire body. I took the hormone test 2 years ago. Results were normal. I've got night sweats and weight gain. Sounds like
yeah, it sounds like perimenopause, my friend. As I said, definitely recommend that you do the test to make sure nothing else is present, but failing that, yes. And what you've highlighted here is one of the shortcomings that we have right now, where a lot of people are doing their hormone test, getting back and it's normal, and then their doctor goes, no man, you're all right, man, yeah, go for it. But it's actually perimenopause. You're kind of perfectly, if you've ever looked at a hormone lab result, it's a range. They have ranges. And when you look on that range, it's so wide. Like they literally have, I had one just like not too long ago. I don't know, I wish I had one drawn up, but it will literally say anywhere from 20 to 200, normal.
Right, right.
And you can fall into that spectrum so easily. Like for you to fall out of it, you are probably way into menopause at that point in time. So you can be within the realm of normal on the lab work, but be going through perimenopause. One does not exclude the other.
Okay, so she should definitely go and
get checked out.
Go get checked out.
Yeah, she definitely needs to go because it seems like it's affecting her quality of life, and I would definitely recommend that you get checked out.
Okay. Allergies. Is an increase in severity of allergy, household chemicals, seafood, nuts. Could this be a symptom of menopause?
Allergies, interesting. So I do not know of that textbook, right? But I would not necessarily rule it out entirely. In that your allergies are a sensitivity issue. And with the fluctuating hormonal changes, etc., you maybe have heightened sensitivity to things. So I wouldn't rule it out entirely at all.
Okay. Again, go and have it checked. I mean, I think that anybody having any kind of symptoms or anything that's just not right, go and check it out. Go and have tests. Go and have an
That's
allergy
right.
test done. Go and have your hormone test done.
Yeah,
Definitely.
And there's always supplements that
Absolutely.
can help to bring down.
Yeah.
How do you differentiate between the headaches that are due to menopause and what we would consider normal headaches?
Hormonal headaches are well, hormonal headaches
Hormonal
are a
headaches.
real thing. Hormonal headaches.
Oh, I heard normal headaches. I was like, what do you call that? Okay,
Well,
hormonal headaches
I
versus.
did say normal. No, Natalie did say normal, but I mean, we get headaches. Everybody gets headaches,
Yeah,
but
okay.
there's something to do with a hormonal headache. How do we differentiate what's hormonal versus I'm having bad headaches?
Yeah, is there a menopause
Okay.
headache?
Well, you can get headaches, right? So you can get headaches in menopause, similar to how you can get headaches during your menses. Just like how you can get headaches, any hormonal flux can cause headaches. Hormonal fluxes can also trigger very severe headaches in terms of persons who have migraines. They will typically tell you that around their cycle, they're even at a higher risk of getting migraines or having the worst set of migraines around their cycle. So they get their migraine, but it's just that much harder to break the pain cycle during their menstrual, the time of their menses. And so, yes, you can get headaches during menopause. Whether there's a different pathology to it, they don't, to my knowledge, don't feel much more different. It's just the pattern of it that you kind of get if you take note. So you may just notice, oh, I'm having headaches. But if you were to take stock and be like, hold on, let me keep a record. Let me document when these headaches are coming. And then you may notice an association. You might know, oh, these are coming when my period used to come, or these are coming at this interval. And then you'll be like, okay, there's something more to this than just it got hot and I was dehydrated, you know? And so it's very important for us as women to take note of our bodies and what's happening. And then when you notice something off-putting, to record it. Be diligent about that, right? Because one, it helps you to identify what's going on, and then it helps you to figure out what's going on with your body, which then helps you to advocate better for yourself when you see your practitioner. Because you might, oh, I'm having headaches, and the doctor might go, oh, okay, oh, you know, time hot, so you're having headaches. I'm like, no, but I actually looked, and what I noticed is this thing happens around this time. And they might go, oh, well, let's take a further look at it then, you know? So it helps you to advocate better for yourself, and it helps your physician to be able to help you better, because the more information you give us is the better we are able to function for you.
Without a doubt.
This one's interesting.
Yeah.
Can menopause cause blurred vision?
Yes, you know, it can actually cause
Really?
visual differences. Yeah.
Thought that was
Because
just
it's the vessels. It's the vessels again. It's the vessels. Yeah, it can.
So basically, menopause affects every part of your body, if you think about it.
It
Well,
does.
your hormones
Because
bathe
your
every cell in
hormones
your body. Yeah.
run everywhere. Yeah, because your hormones run everywhere. And then also with the secondary things like the cholesterol and stuff like that, what that does is now clog your vessels, and so blood supply and blood function is reduced.
Okay, I like this question here about mental illness. So the question was, what are some considerations if you're experiencing perimenopause or menopause along with a bipolar type 2 diagnosis or any other mental illness? I think that that's important because with menopause, it does affect our whole system.
Yeah.
If you're already having a mental illness or anything else going on, how do you navigate the two? How do they come together?
Yeah, so that's a really good question, because it would be a little muddled at that point in time, because you're like, am I just having an episode, or is this something more, etc. What I would say is, again, it kind of comes down to documenting and kind of keeping a record, seeing if there are any associations, and also listening to your body. If you know you've had this diagnosis for 10 years, I'm just calling a number, and you've been stable on your treatment for the last 10 years, and then all of a sudden at 46, 47, you're finding that you're having way more episodes on this medication. You're finding that you're having to upregulate your medication. Every time you go to your doctor, the doctor's going up with the dose, or they're adding another medication. Then perhaps it's a time to stop and say, hold on, doc, could we consider that this could be perimenopause? could we consider that there could be an additional factor, right? And you'll only be able to pick up on that if you yourself are paying attention to those kinds of patterns, you know? But because it definitely, the two can coincide.
Okay. So do you have any other questions here or you want me to go? Okay, so this is a really good question. What happens when you decide to start HRT? What should we expect or what to expect? So we've wrapped our brain around it. We're gone to the doctor. Okay, we're going to start HRT. What can we expect? What should we expect?
So you want to be expecting the good, the bad, and the in-between, potentially, right? Because it's a hormone, right? It's a hormone. I'm not going to pretend like it's a magic drug and there's nothing bad about it or whatever. I really just want people to appreciate that it's safe, right? Whether you want to use it or not use it, that's up to you, but don't not use it out of fear, right? Because it is safe, especially when properly selected for, all right? So yes, you can have the good. You may feel a ton better. You may feel like your old self again. You may feel like, why didn't I do this sooner? You know, you may have complete resolution of your symptoms, right? You may have the bad. You may have side effects. It's still a hormone, right? So just like how some people take the contraceptive pill and when you ask them, they're just like, oh, this is the best thing that ever happened to me. I have no issues. And some people take the contraceptive pill and they're just like, I hate it. It made me nauseous. It made me spots. It made me have headaches. It made me feel all over the place. Similarly, hormone replacement therapy can do one or the other. It can be perfect, or it can give you headaches. It can give you nausea. It can give you all of these other side effects, okay? And so you need to be prepared for either one and mentally note that either can occur so that if you do start to experience it, you're able to pick up on it and go back to your doctor and say, hey, this one's giving me this problem. I want to know how we can adjust for this, or whether we need to change completely or we just discontinue, or what the plan is, all right? And then you can have the in-between. You might be like, okay, this has definitely helped with my hot flashes, but I'm still having a little bit of insomnia, right? You may notice that, you know, my insomnia has improved, but I'm having a little bit of vaginal dryness still. And then you may need to tweak the treatment a little further and say, okay, instead of taking a patch, we're going to do a patch and a cream now to help to offset the other things. In the previous mentioned scenario where I said it helped the hot flashes and insomnia, you might be like, the doctor may say, okay, we've fixed the hot flashes, the insomnia now, let's try the magnesium, let's try some supplements, let's try meditation, let's try, you know, better sleeping habits and, you know, sleep hygiene, things like that. So it may be a perfect fix, it may be a miss, or it may be a work in progress, but it's worth a try if your symptoms are impacting you. If your symptoms are not, live and let live. But if it is, I think it's worth a try.
Is it better to start earlier? Is there danger in waiting longer if you do know that you want to? Okay, go ahead.
Absolutely, absolutely. So what they've found is the sooner you start it is the better. The better for you in terms of your symptom improvement and the better for you in terms of your risk profile. So one of the problems with the WHI, which was the study that they did that gave the bad rep to HRT, was that they chose people who had been in menopause for like decades, right? They had 80-year-old people in this trial, right? And what we found is that the further your body is from menopause, right, is the less tolerant it is of hormone replacement. Okay, let's put it that way. So if you are in perimenopause, meaning you still have your body's natural hormones, but the fluctuations are just weaning and dwindling and it's causing these secondary effects, you giving your body a little top up back to your baseline feels perfectly normal to your body. And your body will function as before. It'll be like, oh, we're back to baseline. Let's do this. If you wait until your body has gone through menopause and your hormones have fallen significantly, what we found is that there are actual changes that your body undergoes the longer you have low hormone levels. And so the further and further you are from menopause is the less your body tolerates replacement of those hormones, because they're just like, but we've already gotten accustomed to this state. Why are you doing this now? It's like, but no, we're not trying to go back. We're trying to move forward type of situation. And so that's when a lot of persons, one, the effectiveness is a little bit reduced. And that's actually the population that now has the risks that we're also afraid of. So that's now when the body starts to have a risk for womb cancer, for breast cancer, and things of that nature. And so the recommendation is that if you've been in menopause for 10 years, you should not do HRT at this point in time. All right. If you're 10 years past menopause, no HRT for you. If
No,
you
starting
are over the age of
if you
60,
started
for
on-
starting, right? If you're over the age of 60, no HRT. It's not recommended in that age population.
That's very interesting. Didn't know that. Yeah.
I know that one of the symptoms of menopause is, or one of the risks is bone density. Right? So bone density. How do you know what your bone density is? How do you know if it's falling? How do you know how to protect it?
Yeah, so there are scans for that.
Okay.
There are imaging scans that can be done to detect on your bone density, because that's actually the most accurate way to kind of predict it, to be honest with you. Any other ways kind of retrospectively are not good, because it's going to be if you after you've had a fracture, after you've had some kind of mishap type of a situation. In terms of things that you can do for bone density to improve your bone density, again, good old exercise is mainstay, right? So exercise and keeping active helps with bone density. Supplementations with calcium, chondroitin, things like that can help you as well. And then HRT also does help with decreasing the loss of bone mass, keeping your bones stronger for longer.
Okay. We have a question in the chat. Is there anything good about menopause? Yes, we're wiser.
I mean, no periods? That sounds pretty good to me. I mean, I'm just saying. So yeah, no periods. Yeah, no periods is always one of people's selling points for menopause. And the truth of the matter is, with no periods comes a lot of different things. So the cost burden of sanitary products, the mood instability that's normally around the periods, once you're able to regulate, otherwise you're fine. So yeah, it definitely does come with its benefits in a sense, but it can be different for everybody. And as I said, not everybody has a bad transition, but I do find that it can be dynamic for most.
Okay, so you're in perimenopause or menopause. What do you say about pap smears, mammograms, all of that? Should we increase the amount that we do? Like say, well, when maybe we do it once a year, maybe we should do it twice a year if we're on hormone replacement therapy. Do you recommend that we do that?
No, the current recommendations are because the current evidence supports the fact that there is very minimal to no increased risk in cancer once the person is properly selected for. We currently recommend that you continue with your regular screening. Now, that being said, a lot of Jamaicans do not do their regular screening. So I would like to emphasize that we are to do our regular screening. So persons are to continue to do their mammograms. Mammograms should not hurt, all right? You should be able to do your mammograms and not be writhing in pain afterwards. I know a lot of patients come and say, Doc, if me never have cancer before, then give me cancer when them do that test, right? It shouldn't be like that, right? It shouldn't be like that. So you should be doing your mammograms. You should be doing mammograms once you're 40 and above. So anybody who is considering perimenopause or symptoms, you should be doing your mammograms already. You should have already started doing your mammograms, to be honest with you. All right. Additionally, pap smears, yes, absolutely. Continue doing your pap smears. Pap smears are indicated up to the age of 65. So you want to keep doing your pap smears regularly. And in some populations beyond. So.
Interesting. That's very interesting. Okay, so let's talk a little bit about sex and HRT because you had talked about that earlier. So we know that we go through that whole vaginal dryness, that low libido, all of that. HRT, obviously we're saying that's beneficial. What else can help women through this? Because it can become very personal and very embarrassing for women. And as we said, couples, partners. What else can we do to overcome that?
Right. So beyond the HRT and everything else that we've already spoken about, there are also procedures that you can do. There are things that can be done to increase vaginal lubrication, things that can be done to increase vaginal excitement as well, to make it more enjoyable, etc. Sorry. Right. So these things include things like the O shot. You can do things like the O shot, which can intensify your orgasms, make the whole area more sensitive so that you can have bigger and better sexual stimulation throughout the process. You can also do energy sources. So there are different forms of energy sources. The personal one, my personal favorite is Thermiva, right? Which we used in the area to help. It's almost like, yeah, it's like a vaginal facial type of thing. So it helps to replenish. Natalie's looking at me like, tell me more. But yes,
No, I'm interested.
the heat
Tell me
helps
more.
to actually, the heat helps to boost the collagen in the vagina. So what it does is it helps with collagen, helps with regeneration, and therefore it helps with lubrication as well and sensitivity. It can also be used on the outside as well to help with plumpness of the vagina, because we're talking about a lot of the other menopausal symptoms, but some of the other things is thinning of all the tissues. So, you know, you get thinning of the skin on the face, but you can also get thinning down there. So you can get thinning of the labia. Persons might notice that their vagina looks a little different and they're just not feeling as attractive or as sexy. And that can be used to help with that. Persons also get some amount of incontinence sometimes as they go into the menopause because of thinning and weakening of the pelvic floor as well. And it helps with that as well. So it helps to kind of rejuvenate the whole vaginal rejuvenation is what it really helps to do. And therefore it's very, very beneficial for persons in this category as well.
What did you call that? Something energy?
Right. So the different forms of energy, the one that I like is Thermiva.
Thermiva.
Thermiva, okay.
Okay.
We have a question in the group that says, oops, I'm 61. What do I do now that I've just heard that I can't do HRT, which had me excited until I just heard that I can't do it.
Oh, no, Anne. All right. So, Anne, all right. When did, I want to ask her a question, but I don't want to ask her too much personal details. With a question about how long ago she went through menopause.
So,
Hi all. About over 10 years.
It's over 10 years. Okay,
Yeah.
Go ahead. I
Every
would not
day.
recommend it for you, Anne. All
Yes.
right. It would depend on your symptom profile, to be honest with you. If you want, we can message a little off air and see what the options are, because it would really depend on what the symptoms are that are giving you your greatest problem. Because as I mentioned a while ago, if you're having, you know, sexual function issues, then there are procedures that we can do to help that. If you're having sleep issues, then there are other things we can do to help that. It would have to be tailored, but yes, HRT would not be ideal for you at this point with estrogen and progesterone. And then that's kind of where the BHRT also comes into consideration now, because then you start to wonder, okay, is testosterone a better option in this situation? But that would have to be very dynamic and very tailored. So yeah.
Okay, I just made an appointment to see you.
Well, hi Anna, see you soon.
That's awesome. Okay, so where do we go? I mean, we start at our gynecologist. Is that, you know, if we want to go this route, that's the first port of call?
Start with your gynecologist, correct. Actually, no, let me tell you what. First thing is educate yourself. Educate yourself. Don't take my word for it, look it up. Do your own research, do your due diligence. Make sure you have some, I mean, you're not going to be an expert in the area. This is not your job, you know, but arm yourself with some amount of information going in, and then make your appointment and go and see your gynecologist.
Okay. And you're still taking patients?
Yes, I'm back in office. I'm taking patients again. I'm off of maternity and I'm back at it.
I have a question. HRT is obviously tailored per person. I mean, this is not when you say we go on the patch or the cream, it's not just a one dose thing. Is it customized per person? So if your hormone levels are this way, your patch will correspond accordingly. Is that how it works?
So it is customized, but not in the way that you're thinking. So it's not like, oh, you need 20 milligrams a day, and 20. That's more of the profile of a BHRT regime. That's how they market it. And that's why they're thought to be more individual and person sensitive. But the truth of the matter is more based off of your symptoms. So knowing that, okay, and what your profile is like. So do you still have your uterus? Okay, well then you're going to need an estrogen with a progestin. What is your main symptom? Okay, let's go heavier on this as opposed to that. So it's because it can't go off of the lab work, because as I mentioned before, your lab work can be perfectly normal, right? You can actually have perfectly normal lab work, but having these symptoms. And so it's not geared towards, oh, I'm giving you 20 milligrams because you are 50 milligrams deficient, and that will bring you to this target point. It's not mathematical like that, but it is tailored.
Okay. When you said that, it reminded me of another question that we have here, where somebody asked, I did a hysterectomy, right? So how does having a hysterectomy, that throws you into full-blown menopause? That throws you into perimenopause? What do you?
No, so, all right, so it depends. Hysterectomy itself doesn't affect your menopausal status because your hormones have little to nothing to do with your uterus. Hysterectomy is a removal of your uterus. Your uterus is simply there for the purposes of childbearing and bleeding, right? Your hormones, actually come from your ovaries. True. Your hormones actually come from your ovaries. And during the hysterectomy, some persons have their ovaries removed and some persons do not. Okay, and that will now determine who goes into what we call surgical menopause as opposed to natural menopause. All right. However, the presence or absence of your uterus does affect the kind of HRT you're going to be offered. All right. Reason being, if your uterus is still there, while it is not bleeding now, because if you're in menopause, it's not bleeding now. If you're in perimenopause and it's still bleeding, well, yeah, it's still bleeding, right? Its presence does pose the risk of womb cancer. And so therefore, the types of hormones and the combination of hormones that we're willing to offer somebody who has their uterus is different from persons who do not have their uterus in. And that's where the difference occurs.
So if anybody else has any other questions, just type it in the chat for us so that we can start wrapping up. I know we started late, but if anybody else has any other questions. There was a question here is, okay, if you don't want to take HRT for whatever reason, we talked a little bit about it, exercise and stuff. Is there anything else that, because it almost seems from this discussion, well, if you don't do HRT, then you're kind of out in the woods, so to speak. How do we coach somebody around that?
No, man. Okay, so if you don't want to do HRT, then no, we'll rely on the other supplemental things. So, and as you said it, you see, Nikki, that's where we go wrong because we say it like that. We say, oh, things like exercise and diet. But no, it's like things like exercise and diet, emphasize it because it really does make a difference, So yeah, doing the exercise, doing the diet, and then tailoring it based on what your problem is. If your problem is the stomach, the stubborn tummy fat, then let's talk about getting you some procedure to get rid of the fat. Let's talk about cavitation, go Natalie, right? Let's talk about all of these other things, right? No, but that's what it's all about. It's about being synergistic, right? Using everything at your disposal. Your doctor is really supposed to be the captain of your ship that's going to pull from all the different possibilities and members to try and get you to a better place. So you say, okay, what is your problem? I ask all my patients, I'm like, especially when they come in with these kind of symptoms. I had a patient earlier, she came in with 2 issues. So perimenopausal symptoms and then some prolapse symptoms. And I said to her, which one's bothering you more? What's the problem right now? What's affecting you on a day-to-day basis? Let's start there, right? If it's at the tummy, how you look is affecting you, then let's start there. Let's fix the tummy. How we're going to fix the tummy, right? Sorry. If it's that, your marriage is falling apart because you're not having sex, well, let's start there. Let's deal with the vaginal dryness. Let's deal with the sexual function. Let's deal with your body image of how you feel about how your vagina looks. If that's why you don't want to have sex with your partner, why don't you want to have sex? Okay, that's the problem. Let's deal with it there, right? What's the problem? Your marriage is falling apart because you and your partner can't communicate. You're moody. You're going at it at all this. Okay, let's start there. Let's get you guys in counseling. Let's get you in counseling. It's not all about medications and hormones. We're dynamic. We're women. There's so many aspects to us. There's so many aspects to what we do on a day-to-day basis, right? We are not one-track things, and there's no one-track answer to any problem that we have, right? So it's really just about being able to pull from the different available treatments for whatever is affecting you at this time.
Perfect,
I
perfect.
think definitely we all have options, and I think that's what everybody needs
I
to
think
know.
you
is
guys
that
got
there-
stuck a while ago.
Oh,
hope
there
you
we
can hear
are.
me.
Oh,
Gosh, we got stuff.
yeah, we got stuck. Are we still there?
There are options.
Okay.
Yeah, just to say that
Yeah,
there
I'm hearing
are
you guys now.
options. Okay, yeah, so there are, just to let everybody know that there are options and that we don't need to suffer and that we do need to speak up about it. And if
Mhm.
you're having issues, go to your doctor, go to your girlfriend, go to your mom, go to anybody and ask where to go, what to do, that we shouldn't need to suffer in silence. And nothing that what you're experiencing has to take you out of the gate.
Come to the life store. We can talk about the supplements.
Absolutely. And I know there was a question, yeah, that you
About where do
wanted,
we find
yeah,
that?
your contact information. I'm going to just pop that in the chat while you,
Sure.
yeah, I'll pop that in the chat for her.
What's the name of your center, Dr. Bridgewater?
It's she, have we gone?
She Women's Wellness Center.
Okay. Well, I know I can get hold of Denise. I'll email you the information, Denise. So thank you so much, Kiri-an. We so appreciate you taking the time to chat with us today.
Thank you so
and
much for
sorry that-
having me. I appreciate it.
Yes, lots of love, and we
Thank you
will
very much.
talk soon. Bye.
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 Bye.